commonest causes of voice problems are short-term upper respiratory tract infections and are managed by general practitioners. But if it goes on for longer than 3 weeks, patients should be referred up to see a specialist. The commonest causes of longer-term problems with the voice are firstly tension, that is tightness of the larynx and the muscles around it. And this can result from either stress and worry, but it can be secondary to other things too. It can be a leftover of an upper respiratory tract infection, or it may be that as we get older we simply are using the wrong muscles to talk with. All of these things can be diagnosed in the clinic. Another common cause of voice problems is reflux. Reflux is epidemic in the Western world. People are getting more and more overweight and their diets aren't as good as they could be. And so acid coming up from the stomach can not only affect the gullet, the esophagus, but it can also affect the larynx as well, causing inflammation and voice problems. The tools that we use in the outpatients are small telescopes that allow us to have a look at the throat. And these may either be passed through the mouth, but more commonly these days we tend to pass them through the nose, which give us beautiful views of the throat and allow us to diagnose voice problems at an early stage and give people accurate treatments and diagnoses. As a laryngologist, I work as part of a team, and most specifically we work with speech and language therapists. They have many functions, and it's best that we communicate together on a regular basis to help the patients achieve their therapeutic goals. When one cord is not moving properly in the voice box, it results in hoarseness, which is very breathy in nature. People find it difficult to generate any power. In fact, they have to produce about 8 times the normal power to get the kind of voice that most people would generate normally. This is very tiring and they run out of breath. Also, because the vocal cords don't come together properly, food and drink might go down the wrong way, and this can lead to problems eating and drinking, particularly problems with fluids, and very occasionally can lead to repeated chest infections. Now, most people with vocal cord paralysis get better over a period of 6 months to a year. And during that time, they can be managed easily by a combination of speech and language therapy and vocal cord injections. Where the paralysis is more permanent, however, we use a different approach. Here we have to push the cords closer together on a permanent basis. And the tried and tested method of doing this is to create a small block of medical grade plastic called Silastic and to carve it into a wedge shape that fits into the side of the voice box and pushes the cords closer together. Most recently, however, we've started to introduce a brand new technique called laryngeal re-innervation. And this is where you can take one of the spare nerves in the neck, yes, we do have spare nerves that don't do very much, and you can connect it up to the paralysed vocal cord to give it bulk, tone and position. This is where the top part of the gullet, which has a sphincter on it called a cricopharyngeus, doesn't relax properly when you swallow. And as a result, pressure tends to build up on top. And as it builds over time, it causes a little hernia to develop. A little pouch forms at the top due to the pressure. Over time, this can get bigger and bigger and is often 3 or 4 centimetres in size by the time it's diagnosed. If it gets very big, it can actually become the preferred route for food. When patients have this problem, the pouch can fill up with fluid and food, and this can spill over onto the lungs and cause pneumonia and infections. Most of the time, however, patients present much earlier than that, with a chronic cough and with a feeling of food coming back into their mouth, and sometimes a gurgling noise in the neck. This is diagnosed by performing a special X-ray called a barium swallow. The pouch can be easily managed in the vast majority of patients. And the commonest way of dealing with it is to pass a telescope under a general anaesthetic through the mouth, down onto the pouch, and then divide the barrier between the pouch and the esophagus using a staple gun. Most recently, we've introduced the addition of a laser to this operation, which allows us, under high magnification, to divide the fine fibres of the muscle that's been causing the problem. This operation used to be a very big operation, but these days patients are generally discharged the following day, just as they are after the endoscopic operation. It used to be almost routine to remove tonsils in children in the 50s and 60s, as they were thought to be the cause of lots of upper respiratory tract infections and ill health in later life. We now know that it's not necessary to remove them routinely. Things aren't really quite so clear-cut, however, and sometimes patients are getting tonsillitis, which is really interfering with their quality of life and giving them a lot of time off work. Tonsillectomy is not to be undertaken lightly, especially in adults. In children, it's a very safe operation with a very low risk of bleeding. Patients in adulthood, having had a tonsillectomy, will have pain for a good week and possibly 10 days, and they need to be warned about that. They also need to have somebody at home with them for a full week. There is no real advantage between the bipolar method, the coblation method and the laser method. They're just different ways of doing the same thing, and different surgeons will have different preferences for these different methods. There is no evidence that any of those three methods really have different outcomes, although the laser one may take rather longer than the other two. Tonsillectomy for snoring can help, but you have to select the patients extremely carefully, and they have to be aware of what all the potential side effects are as well.